Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert. I am here today with my very serious co-host, Dr. Millicent Rovelo.
Super serious.
We need to be serious because we have a serious topic to talk about.
I mean, it's a lot. You told me we were going to do this podcast, and I was like, good thing I'm already drinking champagne from our last podcast. Because it's a doozy.
I know, it's a tough one. Nasal tip aesthetics.
Yeah, that sounds better than how you presented it to me at first. Originally, you were like, let's talk about articulated rim grafts. And I was like, yeah, because who doesn't want to hear about that?
Articulated rim grafts. That's a topic that everyone can sink their teeth into. It's a good one. I'm interested in talking about this because obviously I do a lot of rhinoplasty.
Yes.
And, you know, it's funny because right now I have an intern who's a USC student who's rotating with me who has articulated rim grafts.
Hey, how about that?
So
in the wild.
And in the wild. And she said, hey, can I come and rotate with you and learn about, I'm interested in going into, you know, the medical field and, you know, can I be involved?
Did you do her articulated?
I did her articulated rim. Okay. Yeah, I did. I did her rim grafts. And her nose is beautiful. She looks great. You know, it's like a great rhinoplasty. She looks amazing. And she's thrilled with it. And I said, you know, so how many people who've had rhinoplasty have a nose like yours? And she goes, very few. I go, how many people look at your rhinoplasty and say, oh, that looks great? And she goes, everyone. They love it. I go, it's because of your nasal tip aesthetics. Like the bridge I kind of got right. You know, she's got she had like a fracture and all kinds of other stuff. And she said, you know, yeah, it looks amazing. But the bridge we had to like do some work on.
The bridge being the central part of the nose, the straight lines.
From like the takeoff point of the nose and your forehead to the tip. But her tip looks amazing. And it's because of the way that the architecture was designed with not only her native cartilage, but with the articulated rim grafts.
So let's talk about the nasal tip a little bit and sort of the structures that create it. And then let's talk about how you alter them.
I mean, I don't want to say anything.
But
I'm looking at some articulated rim grafts right now.
Oh, wow.
So just in case anybody was wondering. Just saying, because they do look good. The way that and there's a whole YouTube video that I did during the pandemic because we're wearing masks, which was ridiculous. But I gave a little lecture. It was a 6-minute lecture on YouTube for anybody that has any interest in understanding why the nasal tip aesthetics work the way they do and why it works from a functional standpoint as well as an aesthetic standpoint. There's a YouTube video. You can, I guess, Google search or just look on my Dr. Calvert TV YouTube channel, but it's the Google search would be Lateral Support Dr. J. Calvert or something like that, where I talked about how I decide how to support the tip.
Well, how is the tip usually supported?
Well, that's the thing. In the past, there's been...
no, I mean like without any surgery. Like what makes up the tip?
Oh, so the way that the native tip is supported, the tip of the nose, that is, it's the lateral crura, which are these little cartilages on the side of the tip of the nose. There's the central portion, which are made of the medial crura, the medial foot plates. There's cartilage that goes up the columella.
So that center part of the nose that divides the nose into the right and the left nostrils.
It's this little piece of skin and cartilage in between the nostrils, or as my patient from Jersey called it, the columella. She goes, what's that called? The columella? No, the columella. So if you want to think of it, just remember it's the columella. But the columella is made of skin and cartilage, and it interacts with the caudal septum, the end of the septum, which you can feel if you push up on the columella here, then you can feel the end of your septum.
Which is the cartilage that splits the nose in half.
Right, everybody talks about having a deviated septum.
I had to get a rhinoplasty because I had a deviated septum.
Yes. Sure you did. You had to get a rhinoplasty. You could have just gotten your septum fixed. Well, I figured while they're there, you know, of course, that's the story, and that's how it should be. But anyway, so there's the lateral crura, the medial crura, and then I always talk about the musculature, the muscles of the nose, and there are muscles in the nose. There's the L-san. I'm not going to get into all the levator
Just know that there are
lots of
small
muscles. The nasalis, et cetera, et
tip of
cetera.
the nose.
So all these muscles, and that's why nostrils flare when we get excited, and there's epinephrine in our systems, and the nostrils pull up and to get more oxygen, and those muscles pull, they contract. But the way that I think about support after rhinoplasty, because when I do a rhinoplasty, typically we're trying to reduce the cartilages and make the tip smaller and more aesthetically pleasing, and make some tip suturing to make things look beautiful.
And so you sort of deconstruct the tip.
Correct.
To do what you need to do to make it beautiful, and then you have to put it back together.
Right, and there's a key concept to you rhinoplasty surgeons who are starting out in this field. For those of you who are already in it, you already know this, but the nostril is a ring, and it is a ring structure. And if you understand physics and the forces of these dynamic structures, if you make a weakness in a ring, let's say you make a weakness here, it's going to continue to collapse this way, right? Your weakness will be at the weak point. So typically when somebody has a big fat tip like I do, you're going to trim some of the cartilage here to make it smaller. Well, then you create a weakness. And what happens at that weakness? You get a collapse. Mm-hmm. And that's why if you're a rhinoplasty surgeon and you want to make things smaller and cuter and prettier, you have to take into account that those are actions that are going to weaken the nostril ring. And so with that said, you need to do something to support that nostril ring. So I typically do either articulated rim grafts, which we talked about, straight on floating rim grafts, which are not articulating with the tip, and we'll get into the difference of those. And then I also do what's called lateral curl strut grafts. This is called the lateral crura, this little part of the nostril cartilage. And a strut graft would be a piece of cartilage that just goes under that lateral crura and supports it, and it makes it stronger. Yeah. It's a strut. So
you make it the lateral curl smaller by making it less wide. So you take it from being 1.2 millimeters to being 0.8 or whatever.
Right.
But so it's
0.8 centimeters.
Centimeters. So it's more narrow, and so therefore more prettier and more defined.
But weaker.
But weaker. So then you put some support under it.
Correct.
Through one of these grafts.
And you've also disarticulated the ligaments that hold all this together.
Right.
There's a scroll area that holds up the lateral crura as they come down from the middle vault, from the cartilage vault, this part of the middle vault, which is the bridge. There's a part of that cartilage that holds up the lateral crura. And so by trimming that lateral crura, making it prettier and smaller, you've weakened that natural structure. And so you're going to get a weakness again. You can get collapse, which can cause breathing difficulties. It can look not so awesome.
You can see that usually in old school rhinoplasties where the nostrils are just kind of collapsed and pinched.
Right.
That was someone that had a rhinoplasty and didn't get the support they needed, and so the nostrils collapsed.
And we see that all the time.
All the time, those pinched nostrils.
But we don't see them on my patients, do we?
No, because you have all the options you just listed.
That's exactly right.
And so when would you use one versus the other?
So in general, if I'm repositioning the lateral crura, these cartilages here, then I'll use a lateral curl strut graft.
And why would you reposition them?
Because I've totally detached the lateral crura from all its natural attachments. I've taken it away from the lateral attachments at the accessory cartilages, which I bet you all didn't know, that you have three little teeny tiny cartilages out here on the side of the nose. They're called the accessory cartilages, A1, A2, A3. So I detach that and then move it, and I'll put it into a position that looks nicer. But in order to keep it strong, I'll put a lateral curl strut graft there. If I don't detach them, which I often don't do in primary rhinoplasties, like over here, or my patient who is talking to me about it, who's doing this internship, then I'll do what's called an articulated rim graft, which is a rim graft. It goes on the rim of the nostril. It rides along the rim in the vestibular skin, which is a non-anatomic position because this is skin.
Doesn't normally have
There's
cartilage
not
in
cartilage in here. This is just skin.
Yeah,
but I make a little tunnel.
edge of the nostril doesn't usually have cartilage in it.
Make a little tunnel, put that graft in there, and then it articulates with the tip of the nose. So it is an articulated rim graft. So those are sort of my go-to moves. Sometimes I'll just put in either a lateral curl strut graft, but I'll also use like a floating rim graft here. It just depends on, what the aesthetics are of every nose. Every nose is different. Every nose needs a different, every nose needs a different approach, different attention to detail. And so those kind of different grafts, they comes with experience. Obviously, I've done over 6,000 rhinoplasties. So, to figure out what somebody needs is more about like what I'm doing to the nose to get it to look the way I want to look, and then taking care of the support structures as a, like, okay, this is how I want to look. Now, how am I going to keep it looking this way over time?
And so for those rhinoplasty nerds out there, what's the difference, or when would you use just a basic alar rim graft versus an articulated rim graft? So a basic alar rim graft just being little slivers of cartilage that you put into the skin around the nostril to support it versus actually articulating it and suturing it to the tip.
So let's say somebody has really nice looking lateral curl, but they're a little big and just need to be trimmed. So I would go ahead and trim them, and then maybe just as a matter of preventing nostril notching where the nostril comes up, and also for support, I might just slide in a rim graft for support. That's not, I don't have to, dissect a whole lot of the cartilage and make, a lot of, because when you dissect these things apart, you're making a lot of injury.
Right, you create potential problems.
Exactly. So you make scar and all that. So if I don't have to do that, I'd rather do that, make a little tiny incision, slide a little bar of cartilage in there to hold things in place, and Bob's your uncle. Yeah. You're done. Do you know that expression, Bob's your uncle?
Yes.
Okay. Just want to make sure. A lot of people look at me like, you're not British. It's a British expression. So
yes, I know the expression.
But yeah, I think that's when I do the floating rim. The articulated rim is much more common because I feel like the articulated rim graft not only provides me support, but it also provides me an aesthetic, not like support for my aesthetic tip suturing, and it just makes things blend really nicely, and it keeps things looking very natural while keeping the support in place. So I do articulated rim grafts a lot in primary rhinoplasty.
Got it. Well, very good. That's a very good explanation.
Is that helpful?
It is helpful. I don't do the rhinoplasties, but I always tried to get these little pearls out of you, and I did do it back in the day because I feel like a lot of the times you do these things in surgery, and I've been with you on many rhinoplasties, and you just know what to do because you've done so many of them, and it's kind of second nature. And unless someone really pins you down and asks you, like, why are you doing what you're doing, it's really easy to miss because you're just, and you make it look so easy. And then when we go out and try and do it on our own, it's like, wait, why did he do that? When did he do that?
Yeah, I have an algorithm in my brain.
In your brain, you have this algorithm, and I feel like a lot of the people that are observing you or even watching your lectures and going to your presentations, they don't know the algorithm, and so that's helpful to get out of you.
No, and that's why that YouTube video is really good. But I need to publish a paper on it, and I'm so bad about publishing. Papers.
You have some fellows.
I know. And they're bad about publishing papers also because they get into our fellowship and then they're like,
they're so busy.
This is great. We're busy. Yeah. We're doing surgery. Right. Well, what about the publishing? And they're like,
oh, do I have to?
Ooh, I have a lot of surgery to do, Dr. Calvert. And they do. They have, our fellows are, they are busy.
So busy.
Being plastic surgeons and doing plastic surgery. It is. It's hard to do all the teaching stuff, but you have to do it. It's part of our responsibility to advance the specialty. And I feel like, when you practice plastic surgery, you talk to a lot of plastic surgeons because we're in that mix. And one of my friends who's a really good plastic surgeon said something to me one day that made me like reevaluate my entire existence as a plastic surgeon. And I went back to the drawing board for a second. And he said, he goes, I love doing rhinoplasty, but I'm shocked and stunned by how few patients that I have really like the rhinoplasties I do for them.
Oh, wow.
And he's a good rhinoplasty surgeon.
Huh.
I could critique his results from my standpoint, but evidently he's got patients out the gazoo.
Clearly
he's
busy
as could be. busy as could be with like loads and loads of plastic surgery and rhinoplasty. But his comment to me was, I'm really shocked by how few of my patients like the rhinoplasties.
I could not do that. I could not have that many dissatisfied patients. I would be so miserable every day.
And I went, whoa, do my patients not like the rhinoplasties? And I went back and I looked through and everything. And yeah, I have my unsatisfied patient here and there. I always rant about them on this podcast with you.
We all do.
But they're few and far between. And most of my patients love their rhinoplasties. And so I was like, thank God, because I really sat down and I was like, am I missing something here that my patients don't like it? But I asked them, face on, like, are you happy with this? Oh my God, I'm so thrilled. I love it. And so I think there must be some kind of disconnect in terms of the result. But, for the most part, I think 97.2% of my patients are really happy with their rhinoplasties.
And that would be an interesting study for a surgeon like you referenced. If they're is he happy with their results, but the patients are not? That's
He's
one
very
thing.
happy with
He's
them.
very happy. So he clearly has an aesthetic that
Yes.
he likes. And for whatever reason, it doesn't match with what his patients want. But he's doing exactly what he wants to do. And so I feel like maybe there's just a disconnect between what he is going for and what the patients are asking for. And maybe you and your patients are a little more aligned.
I don't know. He's really he is on top of his work. He's an incredible surgeon. And
clearly
his
he
results
likes
are fine.
his results.
They are. They're not what I would do, obviously, but that means nothing. As we've talked about, every aesthetic of any plastic surgeon is seasoned to taste. Everybody's
Totally.
got their own.
Yeah. I like my food really salty. Some people don't.
Some people don't. And these guys, like I said, that are doing that number of rhinoplasties are competent surgeons.
Totally.
They're really good at it. And, it's all about like buyer beware. Look at the before and afters because that's what you're getting.
That's what you're going to get.
And by the way, on his website, that's what you're getting.
That's what they look like.
It's undeniable that that's what you're getting over and over and over and over and over again. It's undeniable that that's what you're getting. And it's fine. There's nothing wrong with what he does. Again, it's not what I would do. It's whatever. Who cares what I would do? If you like what I do, you come to me. You like what he does, you go to him. But that's where I'm kind of like, how do they not know that that's what they're getting? Because he delivers that over and over and over again.
I mean, it goes back to it's hard for patients to know what to look for in the befores and afters. It really is.
Maybe that's it.
You can kind of get a gestalt. Like, you can tell that patient looks better than they did before.
Definitely.
And so you're just glazing over the befores and afters. Yes, better. And you're not focusing on the details or translating it to what it would be like for you. That's why I love when patients bring me my own before and afters as inspo photos.
True.
Because I can be like, oh, yeah, I remember what I did for that patient. I remember how she started out. And yes, that's totally achievable for you. I got it. That's helpful. But I think, we say look at the before and afters, but I also think it's hard.
It's hard to look at
for
them.
patients to be able to truly critique what they're looking at when, in general, they all look better.
Definitely. There's a change from before to after on all these plastic surgeons' websites. Yeah,
So I would say actually almost as a hint for the befores and afters, because all of us, we just have like pages and pages of galleries of patients, which is a good thing because it means you're doing a lot of surgery.
We do a ton of surgery.
But that's what your eyes kind of start to glaze when you're going through all of them. So maybe pull out a handful and really focus on that handful that you've randomly or not randomly selected and been like, I like this, this, and this, or I don't like this and this and this, rather than just scrolling through pages and pages of photos that, you can't really critique one by one.
Well, and that's why I wanted to talk about, rim grafts, because I use these a lot to get the aesthetics that I create. And it was, my question to my patient was like, how many of your friends who had nose jobs look like this? She was like, none. They don't look like this. And whether that's good or bad, she loves it. She loves her result.
That's the look she wanted.
She is over the moon, and so, yeah, that's what you're going to get. So I thought that comment to me was like, it really it was like, whoa. Yeah, really? what am I doing then? Am I, but my patients really like what I do. And so I think there's a communication level, in terms of your discussion with your surgeon. If you're a patient that's, going in to do this sort of thing, then yeah, you need to have that, that level of discussion.
But not to that level. Like I would not go in and be like, are you going to do articulated rim grafts?
No, you don't know what that means.
Because you don't know what that means,
No.
despite all of the
No, you're right.
explanations. So again,
But you gotta
look at
like
the photos.
results.
Gotta look at the results and be like, so ask them, like, what do you foresee from my tip? Like, if the tip is something that you are really focused on. Some people have a really crooked nose and they just want it straight and they like their tip. But if the tip of your nose is something that is really bothering you and what you really want to be addressed as a main part of the surgery, then really focus on that part of the surgeon's before and afters. And when you go, don't ask him what his technique is, because technique
It's useless.
As long as they get good results, it doesn't matter what technique
Right.
they use. But just ask them, what do you visualize my tip looking like? Like, how do you foresee that looking and turning out? Not necessarily how are you going to do it.
Yep, I agree.
Yeah. Although I would say, ask them maybe how they plan on maintaining those results long term, which I think most surgeons, rhinoplasty surgeons in this area, are probably pretty good at. Doing the support grafts that you talked about.
Yes.
But we've all seen those rhinoplasties done where, like you said, grafts weren't placed in the rims and they're notched, and from the profile you can see right up their nostril. You're like, ooh, should I be seeing that much of the inside of your nose? So just ask them, what do you do, to make sure that these results last, and they'll be able to tell you a few things.
Yeah, I mean, it's just that's why I wanted to talk about this, because I think if you are, so for the surgeons listening, think about how you're going to support that ring structure after you damage it. And then for the patients listening, think about, like, what are you looking for in terms of your nasal tip aesthetics? Because those are crucial aspects of a rhinoplasty, for sure.
Totally.
All right. Well, sorry to take you through this rhinoplasty journey, but
It's all right.
it is important.
It was good. That was good. Good job.
I mean, it's one of those things. Like, I think people, like, you need to know.
You do need to know.
And if you need to know, that's why you're going to listen to us here on the Beverly Hills Plastic Surgery Podcast, because we are coming to you from the 90210.